Welcome, everyone. I think we'll go ahead and get started. So thanks for joining this webinar. Today, we'll be presenting on the 2022 HIV Mid-Year Market Update, which highlights the latest updates in HIV treatment, prevention, and diagnostics. My name is Amy Edmondo, and I'll be presenting today with my colleagues, Jessica Fox and Zach Panos, representing CHI's HIV Access Program. So the updates from today's presentation come from the recently published mid-year market memo, which is available on the CHI website, and the CHI HIV New Product Introduction Toolkit website as well. So on this slide, we've highlighted some of the topics that we'll be covering during this presentation. In the Test Smart section, we'll go over some of the major highlights in HIV diagnostics. In the Treat Right section, we'll outline monitoring and treatment of advanced HIV disease, as well as some market trends in the adult and pediatric ARV space. And then lastly, in the Stay Negative section, we'll cover the latest updates in the HIV prevention space. And then at the end of the call, we'll hold some time for questions if anybody who's joined the call has questions. If you have questions and you don't want to forget them, feel free to use the chat function, and we'll address those questions at the end of the presentation so that everyone can hear what the responses are to those questions. So I'll jump right now into the Test Smart section. So we'll begin with HIV self-testing, where the market continues to grow since the first HIV self-test received approval in 2012. However, to date, pricing has remained a barrier to uptake. Currently, there are 6 HIV self-tests on the market with either WHO pre-qualification or expert review panel for diagnostics, which are outlined in the table to the left. WHO's recent pre-qualification of Abbott's Check Now is particularly exciting, given that Abbott announced pricing for public sector procurement in low and middle income countries at $1.50 ex-works per test, which means that the Check Now HIV self-test is now the lowest cost self-test on the market, which we anticipate will improve access to testing. Pricing has also historically been a barrier for dual HIV and syphilis testing, which have the potential to integrate and streamline services, enabling more countries to eliminate mother-to-child transmission of HIV and syphilis. So access to these tests is particularly important for pregnant women, given that there are over 200,000 stillbirths or newborn deaths due to syphilis per year, which accounts for the second leading cause of stillbirths worldwide, and could be prevented with testing and treatment. Years of advocacy, advances in testing, and program implementation in the ANC space mean that nearly 95% of women are tested for HIV at some point in their pregnancy. However, less than 50% of women are tested for syphilis in pregnancy. A volume guarantee from CHI and SD Biosensor in November 2021 seeks to improve access to HIV and syphilis combination testing for 95 cents ex-works per test in 139 countries. As you can see on the right, the 139 countries covered in this pricing agreement account for 93% of the global burden of HIV and an impressive 98% of the global burden of congenital syphilis. This new price is an opportunity to catalyze the use of dual HIV syphilis tests into existing antenatal care platforms to close the testing gap between HIV and syphilis, increasing the rates of maternal syphilis diagnosis and linkage to treatment. So I'll now hand it over to Jessica, who's going to talk about the advanced HIV disease space.
Great, thanks so much, Amy. So we'll turn now to our Treat Right section and begin with treating right by addressing advanced HIV disease. Next slide, please. Thanks so much. So a key step in being able to treat advanced HIV disease, or AHD, is identifying patients with low CD4 counts. So to this end, scale-up is ongoing of the Visitech CD4 Advanced Disease Test, which is a groundbreaking device-free, same-day CD4 test, and it's available for procurement at a price of $398 US ex-works in over 130 lower and middle-income countries. Since the first Visitech order in August of 2019, adoption of this product continues to pick up speed. This time last year, there were almost 100,000 tests ordered, And as of April 2022, there are now 309,000 tests ordered and 34 countries where tests have been delivered. And these countries are highlighted in the map on the right side of the slide and include countries across the globe. It's exciting to see this level of adoption, as this test could help to significantly improve same-day identification of advanced HIV disease, allowing rapid linkage to appropriate care. Now, another key step in addressing AHD is identifying and treating opportunistic infections. And tuberculosis, or TB, is one of the most common opportunistic infections among people living with HIV. And in 2020, 5,000 more deaths from TB occurred among people living with HIV compared to 2019, which is the first time that we've seen an increase in the number of deaths in over a decade. And we've highlighted this in the graph at the bottom left, where you can see that there were 214,000 TB deaths among people living with HIV in 2020. And in light of this, access to short course treatment regimens remains critical. Now, if we turn to the right side of the slide, which focuses on TB preventative therapy, we can see that supply continues to ramp up. So we'll be focusing on isoniazid rifapentine, which is a fixed dose combination of 3-HP, a TB preventative therapy. Now here, supply constraints are easing and McLeod's is scaling up production capacity. McLeod's will also continue the $15 per pack access price through 2023. Lupin also received Global Fund ERP approval for isoniazid rifapentine in May 2022, adding a second supplier to the market. Now, despite these improvements in supply, the APWG continues to allocate orders for isoniazid rifapentine in keeping with the tiered rollout plan agreed by key partners implementing 3-HP scale-up. So another update in the TB space was the release of the updated WHO consolidated guidelines for the management of TB in children and adolescents, which aims to improve TB management, including among children with AHD. And we've highlighted some of the major updates to the guidelines on this slide, including the expansion of diagnostic testing to include non-invasive specimens, such as stool samples. There's also a new recommendation for children with non-severe forms of drug-susceptible TB to be treated for 4 months instead of 6. Rapid molecular diagnostics are also recommended as the initial test for TB diagnosis for children and adolescents. And finally, new models of decentralized and integrated TB care are recommended, which could allow more children and adolescents to access TB care or preventative treatment closer to where they live. And then to close out this section, I'll give a few updates on treatment for cryptococcal meningitis, another opportunistic infection common in people with AHD. And we'll be focusing on flucidazine, or 5-FC, and liposomal amphotericin B, which are key drugs for the induction phase of cryptococcal meningitis treatment. So let's start with 5-FC on the top left. We've seen a sizable increase in the order volumes for this product through the ARV Procurement Working Group, or APWG. Orders increased by over 104% between 2020 and 2021. Viatris is also anticipated to receive approval for a new API source and will likely reinitiate supply in Q2 or Q3 of 2022. There's also a new supplier, Strides, who has commercialized 5-FC for LMICs with the first batches available from June 2022. For liposomal amphotericin B, order volumes seen by the APWG are also rising, with a 672% increase between 2022 and 2021. Adding to this, Sun Pharma received US FDA approval, the first generic supplier and the second supplier of liposomal amphotericin B. And they're currently working to develop an LMIC pricing and access strategy. Now, we expect liposomal amphotericin B to play an increasing role in the treatment of cryptococcal meningitis. And this is due to the results of the Ambition CM trial, which we highlighted on the top right. The trial compared the standard of care treatment with amphotericin B deoxycholate with liposomal amphotericin B, and found that one high dose of liposomal amphotericin B is non-inferior to the standard of care with 1 week of amphotericin B deoxycholate. And this has the potential to drastically simplify cryptococcal meningitis management, reduce toxicity, and lower costs. And as a result, the WHO issued rapid advice recommending a single high dose of liposomal amphotericin B, as shown in the quote on the bottom right. New WHO guidelines with this recommendation are expected shortly. So now I'll hand it over to Amy again to walk us through updates in the adult treatment space.
Sorry, I was not unmuted. Thanks, Jessica. So in this section, we'll go over, like Jessica mentioned, the latest trends in adult treatment, and we'll also discuss the introduction of new optimal products and review some updates from the ARV pipeline. Sorry. Okay. So on the topic of adult treatment, we're increasingly seeing more people on dolutegravir-based regimens. Since the approval of TLD by the US FDA in 2017, we now estimate there are over 18 million people on TLD across first and second line treatment in low and middle income countries. As demonstrated on the graph on the left, countries are increasingly reaching market saturation of TLD in first line. We estimate that in 2021, 86% of adults on first line therapy were on TLD. A number of countries have completed first-line transitions and are now beginning to transition stable second-line patients on protease inhibitors, such as lopinavir/ritonavir, to DTG. You can see on the right side of this slide a sample of countries who have taken advantage of the clinical and cost-saving benefits of TLD in second line. We expect this list to grow over the next few years, though this list is not exhaustive. So to speak a little bit more about second-line optimization, results from the VISEND and NADIA trials continue to demonstrate the potential for NRTI backbone recycling of tenofovir and lamivudine in second line. So starting on the left, VISEND explored the efficacy of DTG with recycled NRTIs as compared to boosted PIs with new NRTIs. It also compared TDF and TAF when combined with DTG. So to do this, participants failing a TDF and NNRTI-based regimen were randomized to receive either TLD or TAF with DTG, or a PI-based regimen in second line. 144-week results indicate that TDF or TAF with DTG in second line is non-inferior to PI-based standard of care with switched NRTIs, as you can see in the graphic below on the left. On the right, NADIA explored the efficacy of both DTG and dronabinol/ritonavir when prescribed alongside an NRTI backbone that was not predicted to be active due to resistance. It also explored the current WHO guidelines, which is to switch an NRTI backbone when moving a patient from first to second line, which is demonstrated in the simplified chart of study design on the bottom right. 96-week results reconfirm earlier findings that DTG and dronabinol/ritonavir are equally effective in second line, and that retaining TDF is non-inferior to switching to AZT in second line. These results re-emphasize the importance of second line switching to DTG or dronabinol/ritonavir for those who are unable to take DTG. Further, these results combined with VISEND support backbone recycling of TDF 3TC in second line. While WHO guidelines have not been updated yet, groups like the Southern African HIV Clinician Society endorse backbone recycling in second line. So one of the most exciting updates in the adult treatment space is the approval and introduction of the protease inhibitor dronabinol/ritonavir in the 450 milligram fixed dose combination formulation. This is a long-awaited product for use in second line in low and middle income countries. As we've indicated on the left, generic dronabinol/ritonavir from Hetero Labs is WHO pre-qualified and available for $17.50 per pack ex-works, thanks to a CHI and Unitate incentive program. On the right, we've outlined some of the key benefits of dronabinol/ritonavir. These include a high genetic barrier to resistance, improved viral suppression compared to lopinavir/ritonavir, better tolerability compared to other PIs, the ability to reuse dronabinol/ritonavir in third line at a higher dose, and now with the incentive program, it's actually slightly cheaper than lopinavir/ritonavir, which would allow a number of patients to access this product in second line. So we're very excited about that. Further, PEPFAR in their latest COP guidance encourages the use of dronabinol/ritonavir, provided it's both available and affordable, for those patients who can't take TLD. Targeted introduction of dronabinol/ritonavir is starting in 3 countries, Botswana, Nigeria, and Zambia, for those patients who experience treatment failure on DTG, with early data expected later this year. We encourage partners to explore product introduction resources for darunavir/ritonavir via the HIV New Product Introduction Toolkit website. These include things like a clinical action memo and resources for health workers, as well as training slides and a prescribing algorithm and an FAQ document for those who are interested. So as we know, taking treatment is only one part of the equation. Viral load testing gives healthcare providers guidance and allows them to monitor a patient's response to ART. Historically, viral load testing has been conducted at central laboratories. However, a movement toward point of care or near point of care viral load testing aims to bring these tests closer to the facilities where patients receive care while also expediting clinical action and viral suppression. So a recent CHI-supported study in Zimbabwe found that pregnant women who were tested on near point of care viral load platforms at the facility were 4 times more likely to receive the results within 30 days of testing. And of those with a high viral load, they were 8 times more likely to receive clinical follow-up action within 30 days of testing, as compared to centralized testing. These results are demonstrated on the right side of this slide, within the graph on the right. So these findings support WHO guidelines, which indicate that pregnant women are a priority group for point of care viral load testing. Now moving on to the treatment pipeline, newly approved longer acting products, as well as those under development, offer exciting possibilities in both treatment and prevention. However, progress was impeded this year by a number of clinical holds. So starting with injectable ARVs on the left, cabotegravir and rilpivirine was approved by the US FDA early last year for monthly treatment of HIV. Follow-up 96-week results from the Atlas 2M trial, as indicated in the graph, found that CAB and RPV dosing every 8 weeks is non-inferior to monthly dosing, which led to an updated dosing schedule by the US FDA in February of this year. Lenacapavir, which is a capsid inhibitor, is also being studied for treatment as well as prevention in the form of a 6-month injectable. To date, the Capella and Calibrate trials have shown that this injection provides sufficient viral suppression. Late last year, the US FDA issued a clinical hold on lenacapavir over concerns related to the compatibility of the glass vials that are used to store this injectable ARV. However, this hold was recently lifted after Gilead proposed an alternative vial, and we expect that clinical trials will now resume. So moving to the right, islatravir is being studied for the treatment of HIV in a daily oral formulation combined with doravirine. To date, results from the Illuminate Switch trials have shown that doravirine and islatravir produces viral suppression rates comparable to currently existing ART regimens. Islatravir is also being studied for prevention and oral and implant formulations. But unfortunately, a clinical hold was issued in December 2021 based on total lymphocyte and CD4 T cell counts in some participants that were receiving this drug in studies. A weekly oral formulation of islatravir and lenacapavir is also being studied for treatment-experienced, virally suppressed people living with HIV in the US. However, trial enrollment was paused based on that clinical hold I previously mentioned for islatravir. And it is currently unclear if or when this hold will be lifted. So with that, I've wrapped up the adult section, and we'll move on to trends in the pediatric ARV space. So to kick off the pediatric section, we'll discuss dolutegravir 10 milligrams dispersible and squared tablets, or pediatric DTG, where we've seen rapid and widespread adoption of this optimal product. This is particularly important given studies show that children consistently have lower viral suppression following ART initiation, as demonstrated on this top left graph. This reinforces the importance of transitioning children to more effective products like PEDS DTG. So far, over 40 countries have placed or received orders for PEDS DTG as of the first quarter of this year. However, we have seen some uptake slowed by viral load requirements, despite the fact that WHO guidelines emphasize that viral load monitoring remains a good practice, but should not be considered a precondition to PEDS DTG transition. And this is also reiterated in the WHO optimal formulary. For additional information and resources to support the introduction of pediatric DTG for children 3 to 20 kilograms, we encourage partners to check out resources on the HIV New Product Introduction Toolkit website. So looking ahead, there are several pediatric products currently in the development pipeline. However, countries should prioritize PEDS DTG transitions to allow children to access the best available treatment as soon as possible. So the first product I'm going to highlight on the left side of this slide is fixed dose pediatric ABC 3PC DTG, also known as PEDS ALD. So in March 2022, the US FDA approved ViiV's dispersible tablet formulation for use in children 10 to 25 kilograms. Now, CHI and Unitaid are working to bring a generic version of this product to market. But programs should not wait for the triple fixed dose combination and instead should take rapid advantage of the PEDS DTG singles. Moving to the center, pediatric darunavir-ritonavir is a best-in-class PI with use planned for children experiencing failure on DTG-based therapies. However, high API costs and low volumes have been historical barriers to development of this product. CHI and Unitaid launched an incentive program and a request for proposals to catalyze the development of this product in September 2020. Loris Labs was awarded the incentive contract as the generic development partner. Lastly, on the far right of this slide is pediatric TAF. So this is a potential for use as a backbone NRTI in pediatric patients, pending clinical data. Penta received a grant to investigate dosing and other clinical data, and CHI is supporting as the formulation development partner for pediatric TAF. So I'll now hand it back to Jessica, who's going to wrap us up with a discussion on trends in the HIV prevention space.
Great, thanks so much, Amy. So let's go ahead and dive into some of the key prevention updates. Great, thanks. So we'll begin with some major product development and regulatory updates. So first looking at cabotegravir long-acting injectable, or CABA, which has been approved by the US FDA for at-risk adults. However, many steps remain prior to introduction in LMICs. So in December 2021, CABA was approved by the US FDA for HIV PrEP in at-risk adults and adolescents weighing at least 35 kilograms. It's administered every 8 weeks after the first 2 doses, which are 4 weeks apart, and it is a highly effective injectable option for HIV PrEP. On May 27th, 2022, ViiV committed to voluntary license CABA, which is a critical first step in enabling widespread, affordable access. However, while generic development progresses, ViiV will be the sole global supplier of CABA, and work is needed to ensure sufficient affordable access to the product during that time. Now, in addition to the need for licensing, there's also still some additional research and evidence generation that is needed, which is highlighted on the right side of the slide. Currently, Unitaid and USAID are planning implementation science projects to inform further evidence generation. Additionally, laboratory analysis of the HBTN-083 trial, which assessed the effectiveness of CABA, found that use of an RNA assay at screening may help identify HIV infections earlier and reduce the risk of INSTI resistance. So underscoring this, the US FDA product label recommends RNA testing at initiation and each injection, and further modeling is currently ongoing to assess benefits of RNA testing in the context of resistance risks compared to reduction in AIDS-related mortality. So as we look forward to think about what will be required for CABA introduction in LMICs, there are a number of steps remaining. So first and critically, ViiV needs to agree to licensing terms with generic suppliers and a price commitment, which ensures equitable access to the innovator product in the interim. Additionally, the WHO is in the process of reviewing evidence to inform CABA guidance, which is expected mid this year. We'll also need coordinated planning between communities, donors, and governments, and implementation tools to support efficient delivery need to be developed. So many steps still required, but a very exciting and transformational product for the prevention space. Another new product on the market is the Dipi vaginal ring. However, the International Partnership for Microbicides voluntarily withdrew its US FDA application for the Dipi vaginal ring in December of 2021. This decision was based on feedback that approval was unlikely based on the current data and given the context of the HIV prevention landscape for women in the US. The WHO does still conditionally recommend the ring alongside oral PrEP as a choice for women who do not want or are unable to take a daily oral tablet. However, they also note that daily oral PrEP, when taken as prescribed, has greater efficacy than the Dipi vaginal ring. The Dipi vaginal ring has also received national regulatory approval in Zimbabwe and South Africa, and will be offered in introduction studies in LMICs. So looking forward, the development of the dual prevention pill, or the DPP, to prevent HIV and pregnancy is underway, which represents a really important opportunity to stimulate HIV and sexual and reproductive health integration. So the dual prevention pill is a multi-purpose technology that's under development for daily use to prevent both HIV and pregnancy. Bioequivalent studies are ongoing, with US FDA submission currently estimated for late 2023. And CHI is engaged in advanced planning for the introduction of the DPP and also to inform broader needs for efficient multi-purpose prevention technology introduction. So there are a number of areas where further evidence is needed, and we've highlighted two here, although this list is certainly not exhaustive. The first is data on HIV risk among oral contraceptive users. So current oral contraceptive users are likely to be a focal population for the DPP. However, there's limited data around HIV risk in this subpopulation, and additional evidence is needed to inform quantification. Second, further evidence is needed on user preferences on dual indication products among contraceptive users. So various preference studies have consistently found that users would prefer a product that combines HIV prevention and contraception compared to a single indication HIV prevention product. However, the preferences of contraceptive users specifically is not well understood, and further data is needed. And as we think about potential future, thanks so much. And as we think about potential future introduction efforts, we've illustrated a few examples of what will likely be required. And this includes preparation of M&E systems to support the introduction, given current planning silos, and integration of supply chains for family planning and PrEP commodities to help facilitate delivery. And then finally, as we look to the future of patient prevention choices, it's going to be critical to ensure that we have adequate funding. Currently, HIV programs and prevention research face stagnating funding, which we can see on the left side of the slide, where we've graphed global HIV prevention research and development funding from 2010 to 2020. And we can see here that funding continues to decline, with a 4.4% decrease in 2020. And as we look forward, prevention funding, specifically funding focused on access, will be critical to support new product introduction for some of the products that we just discussed. Now, looking forward, sustainability will also be a critical piece of the puzzle. And in Zambia, they've been making strides towards achieving this in their voluntary medical male circumcision, or VMMC programs. So in 2021, progress toward country-defined VMMC sustainability targets increased in Zambia, despite ongoing COVID impact, which we can see in the graph on the top right. And we've highlighted a few of the enablers for sustainability on the bottom right, and they include static service delivery rather than campaign-based services, and inclusion of VMMC as an essential service during lockdowns. So focus on this kind of sustainability transition, as well as implementation-focused funding, highlighted on the left, will be critical for future prevention work. So that concludes today's presentation. Thanks so much all for your time and attention. Happy now to open it up for a few questions or comments, either in the chat, or I believe you can raise your hand. So we'll pause there for questions. All right, well, if there are no questions, I think we can go ahead and end here. As I mentioned, thanks again for your time and hope everyone has a great rest of their day.